Hello, everybody. I am delighted to introduce Dr. Eleni Linos, who is a professor at Stanford University in the Department of Department of Dermatology, Medicine, and Epidemiology, and a star in geriatric dermatology. And I've been lucky to know Dr. Linos since I think it was 2012 when you got your UCSF CTSI KL2 award, right? And you were in the K Scholars Program, and I was one of your advisors. So we go way back. And so you were UCSF faculty member in dermatology until 2019 when then you went to Stanford. And you've collaborated with a lot of people in geriatrics and have done really pivotal work on incorporating life expectancy into the treatment decisions of older adults with basal carcinoma, as one example. And you've also done innovative research that has led to you having a prestigious Beeson Award, which is the Emerging Leaders in Research Award, and you hold a K24 Mid-Career Mentoring Award for research in vulnerable populations with skin disease, as well as an R01 focused on novel digital tools for home-based monitoring of skin disease. You're also PI now of the Stanford CTSI K Scholars Program, so full circle. As well as the Director of Diversity in the Department of Dermatology and Director of the Stanford Center for Digital Health, not to mention co-chair and founder of the Geriatric Dermatology Expert Group for the American Academy of Dermatology and Director of Research for the Physician Mothers Group. So I thought these were all great things. I could probably go on and on, but I want to leave time for your presentation. So anyway, give us I already sent a warm welcome for Eleni to give us a talk today.
Thank you. And let me see. Hello to everyone on Zoom and then full screen. Okay. And I'm assuming, and
Yeah,
we don't
we
need
see
this. Perfect. So, yeah. So hi, everyone. This will be tricky talking to the Zoom people and to the audience, but I'm not ignoring either of you. But I just want to say I'm so happy to be here. I met with your fellows just now, and they were like, "Oh, so this is probably a reunion for you," and it really does feel like a reunion because, as Louise said, I started my career here at UCSF, mentored by Ken and Louise and other amazing people in this department, and it really feels like I'm, coming home. And even though I'm a dermatologist, is it audio?
the screen is just switched. We're going to switch these. So
I feel so honored to have been mentored by all of you. And for those of you who are trainees, know you are so lucky to be in this division and associated with this division, because so many other parts of academia, other universities, and other departments, even at UCSF, are nowhere near as supportive. Like, you have the rare combination, I was telling the fellows, of having brilliant scientists who are also really, really nice people. And that's so rare. And so appreciate it, because it definitely helped build my career. And I wouldn't be where I am in my career without this support. And you guys are so lucky to be in this environment and have these colleagues. So briefly, just to mention, I still have no financial conflicts of interest, even though I lead the Stanford Center for Digital Health. I'll tell you about that at the end. And that's partly, someone told me recently to start explaining that that's intentional. And it's so that I can say when I publish papers and when I give talks, that I have no financial conflicts of interest. So practically what that means is when companies do try and ask for consulting advice or to, buy you lunch or whatever, I've chosen to actively say no to everything so that I can have this nice checkbox of no, for now, no financial conflicts of interest. And then at some point, if I ever decide to change that, it'll, be an intentional decision. But anyway, thought I would explain that a little more. So to tell you a little bit about my path, I'm a physician scientist. And my goal is really to tackle critical research questions that have an impact on people's lives. I'm very focused on reducing disparities and improving the health of vulnerable populations. I'm also very passionate about science communication, and my career has also demonstrated a lot of perseverance just because I've had to deal with failure, and creativity, again, because you have to adapt to failure. So failure is a key part. And really, my work has always focused at this intersection of dermatology, technology, and public health. But I get distracted easily. And so I also, started working on geriatrics and aging, which I'll talk about today, have done some work in mental health, diversity and gender equity, and skin cancer. I started mentioning my family early on in talks, just to give you a background of how I got here. So my parents on the left, I grew up in Greece, and my parents were both physicians. My mom was an epidemiologist, and these are my three sisters who are all academics as well, and they work in public policy and law and public health at different places in the US. And so I feel I have this like home think tank of generally wise social scientists that can tell me, they're kind of, I can bounce ideas off. And whether it comes to wording of a paper or talk, it's very helpful to have, and you don't need to have four sisters for this, but developing your peer group that you can bounce ideas off. And of course, my mentors, many of whom are in this room, but also my PhD mentors, Graham Colditz and Walt Willett at HSPH, and Meg Kren, who many of you probably know, who is now the chair of dermatology at Vanderbilt, but was here for all the years I was at UCSF too. So, now my goal is really focused on conducting research on how to apply technology wisely. And I think that word wisely comes from the field of geriatrics, where you are always thoughtful about, what is best for patients, for more inclusive and equitable care. And really, I've always had a focus on the needs of older adults. And it's been an honor to get formal training with you on this. And then, leading the KL2 program now, as Louise mentioned, coming full circle from being a KL2 scholar mentored by Louise and Ken to now co-leading the KL2 program, it's just a joy to be able to pass this forward. And what I try to instill in my trainees is not just doing rigorous science, that's really important, but then thinking about what impact this science has on the lives of our patients, on our planet, on our health system, on our physicians. So I'll tell you a little bit about the, one research story that was my KL2 work and my work at UCSF. And this is this very common clinical scenario that many of you see, which is a skin lesion on a patient's, on patient's thigh. But then obviously these patients may be very, very different. And I don't need to explain, this to this audience, but for dermatologists at the time, we really were very focused on the lesion, whether it's under the microscope or on the skin, and kind of we're not really taught or trained at looking at the whole patient. And some of the work we did, hold on, I might minimize this so I can see, whoops. Oh, well, I can't see part of my slide there, but that's okay. I can see it here. One of the first studies I did as a resident was at the VA at Stanford, looking at low-risk BCCs that were transected, so they weren't completely removed, and following them over time to show that really the majority of them did not recur. So over 90% of these low-risk BCCs, even though they were never completely excised, never came back. And maybe instead of jumping into the research questions, I'll tell you the story of the patient that inspired this work while I was a resident at Stanford. And it was this gentleman who, as a first-year resident, would come to the VA, and every month I would take a little piece of his ear off to biopsy it because it was suspected BCC. We'd go up to the path room a few days later, look at it. And while we were in the path room looking at the scope all together, we had this notebook where we would decide the follow-up and the management in the microscope room. And then there was a phone there. So after we finished path, we would essentially put in the order for Mohs, call the patient, say you're scheduled for Mohs. So at no point was there, a point where we called the patients and asked them what they wanted. It was literally from the diagnosis to the scheduling. So I did this for this poor man several times, because then I would say in 3-month follow-up, and he would come back after his Mohs, and I would find another BCC right next to the original BCC. And I was so proud that I found another one. And again, path, microscope, call, schedule Mohs, follow up in 3 months. And I did this repeatedly until we had slowly chipped away at his ear. And then when I called for follow-up at some point, he had passed away. He had died of an unrelated cause. And then I realized that my whole pride as a derm resident at finding these BCCs and scheduling his Mohs was actually potentially harming him. The last few, months of his life were, really wasted coming back and forth to our clinic. And that's when I started reading a lot of the work that was pioneered in this department and realizing that really maybe there was something wrong with the way we were approaching care of BCC. And the research questions we had were, how are we treating BCCs in patients with limited life expectancy? And then how common are these patient-reported problems from treatment? So this is some data, again, in collaboration with Ken and Louise here, where we showed at both a prospective cohort study here at UCSF and the VA that patients with limited life expectancy received surgery just as often as young, healthy patients. We repeated this nationally and showed the same thing, that basically the proportion of different treatments, whether it's Mohs, surgery, or destruction, doesn't seem to vary regardless of a patient's age, whether they were in their last year of life, whether they were dependent in activities of daily living, or whether they scored highly on, the life expectancy scores and metrics that you all know so well developed here, the Charlson and Lee indices. So, were we following a one-size-fits-all approach in dermatology with most tumors treated surgically, and treatment choices not affected by life expectancy, even when we adjusted for patient tumor characteristics? And essentially, we showed that with data on a national and prospective cohort, validating that experience that I had had as a resident, that really we were definitely not considering these factors, and we were treating the tumor, not the patient. I was also very interested in how patients experience problems after these treatments, because if you at that time asked a dermatologist about this, they would say, well, but it's so easy. It's so, it's nothing. I do this in an hour and they're awake and they love me because I'm such a great surgeon. So that was, the response. And we were all surgeons are great. No doubt about that. But we were lucky enough to have this prospectively collected data on complications. Again, this was Meg Kren's cohort that had, I think, almost 2,000 patients in it, followed prospectively with basal and squamous cell carcinoma. And the question patients were asked was, in your opinion, were there any complications of your treatment during or after the treatment itself? For example, excessive bleeding, infection, et cetera. So patients were able to score whether they felt they had a complication and describe this. And I remember when we analyzed this data, I thought I had made a mistake. Like I kept checking and rechecking, because 27% of patients had said yes to a problem. 27% is 1 in 4. That seemed way too high of a response. But we actually pulled the actual questionnaires, because they were paper-based, and checked them, and this was true. And actually 38% ranked it as moderate, very, or extremely severe. And then when we looked at those descriptions of what they were, 14% of the entire cohort reported a medical complication. So they were bleeding, infection, wound dehiscence. These weren't just problems related to insurance or parking, even though obviously those are important too. So then we went back into the charts and tried to find from those patients how many of the physicians had recorded the complication. And we found this big discrepancy between 27% of patients saying they reported a problem or a complication, but only 2.5% of the medical charts, the physicians recording them. And I believe this is known in other fields too, in oncology with chemotherapy and other medications, that really the patient's experience may be different from what the physician records in the chart. And interestingly, only 7 of 22 physician-reported complications were also reported by patients. So really, there was this big discrepancy. This body of work is also summarized, inspired by Louise Walter, who I still remember gave us a talk at the KL2 program on how to write a viewpoint article. And hopefully you have had the privilege of hearing that from Louise, but her talk on how to write a viewpoint inspired me to summarize this in a viewpoint that was published in JAMA when I was, I think, junior faculty here, and then followed the theme of writing viewpoints to articulate a new idea, a new concept, by publishing this other kind of summary or viewpoint piece on geriatric dermatology in JAMA Derm for dermatologists, giving a framework for caring for older patients with skin disease. Now, the principles are not new to you, so I don't need to repeat them, but essentially we went through all the principles of caring for an older patient and concluded that we need to explicitly incorporate principles of geriatrics in the practice of dermatology, the same way that principles of pediatrics have been incorporated into pediatric dermatology, which is its own field and fellowship for years. And so, that really, I think, helped at least put certain phrases and words into the language of dermatologists and the derm training today. The New York Times, has obviously picked up a lot of these stories, and I was very proud when they really identified skin cancer treatment as one of the areas that needed, perhaps rethinking. And this led to another really fun study and story I'll tell you about today, which is this got us thinking, well, what is the natural history of untreated BCC? So what we noticed clinically, the other story is that a lot of very educated retired physicians would come to our clinic and say, this is a BCC. I know it's a BCC. I've had them before. Don't do anything. So a lot of dermatologists know this, that people who know exactly what it is will choose new treatment. But that led us to think, well, what is the natural history of untreated BCCs and how do we measure that? So we designed this, as I mentioned in the beginning, I'm Greek, and at the time there was this wonderful article about the island of Icaria that was published which is one of the blue zones where people live a long time. And I remember being in Meg Kren's office here at UCSF, and we were looking at the photos in this article of all these very happy 90, 100-year-old Greek people portraits, and thinking like, I see skin cancers on all over their faces, and there they are, like smiling. And so, she said, oh, if only we could go and measure their, the number of skin cancers. I was like, we can, Meg, we literally can do this. It's not impossible. So we actually, set up this pilot study in Icaria, and we traveled, we did 4 visits over 2 years, and had waist-up skin exams with 2 dermatologists. And I'll show you some beautiful photos of of us in Icaria. I haven't been able to repeat a study in Greece, but this was very, very nice. And, what we showed, we enrolled 90 participants, and our participation rate was 95% because people were delighted to join. I can talk later about IRB, informed consent, why this was an ethical study, because we thought about that very, very carefully. And we had 65 participants that had at least 2 study visits, and 86 lesions included that were suspicious for BCC. Our mean follow-up was 18 months, and we found that about half of these basal cells increased in size, but the other half did not. So 36% stayed the same, and 10% resolved, were not there. We could not find them at follow-up, and 5% were treated surgically. So our conclusion with this preliminary data, which again has lots of limitations, was that there was significant heterogeneity in growth patterns because half of these lesions seemed to increase, but about half did not increase in size. And then, we believe, again, it's a small pilot study, and we had a long follow-up time between visit, but a small proportion seemed to spontaneously regress. And this is not unheard of in the literature of both melanoma regression as well as some early breast cancer regression. So it's not biologically impossible, but it was surprising. And then what's really interesting is a few years later, this amazing Dutch group that also was kind of sold on this idea of not treating basal cells did this wonderful study, and this was an observational cohort study of 280 basal cells in 89 patients in the Netherlands. And they found essentially the same thing. So they found that about 46.8% of tumors that were prospectively followed untreated increased in size. They have characteristics on which types of tumors did, and the rest did not. They estimated a very slow growth rate. And then they concluded that watchful waiting may be an appropriate approach to patients with with BCC and limited life expectancy, especially asymptomatic ones. And these were some of their photos, again, showing that heterogeneity. So what we learned is that the biology of these tumors really varies. We then decided to design this decision aid for the treatment of low-risk basal cell carcinoma. And some of the challenges we've had with the derm community in discussing this are, this concept, they always bring up this idea of neglect and whether or not, the handful of tumors that have grown and are inoperable in often patients that do not access care for a long time. Convincing dermatologists that this isn't about chronological age, but about life expectancy. Another challenge has been the ethics of conducting a study of watchful waiting or non-intervention, especially in an international setting. And then in a bit, I'll talk about digital access and home monitoring. But what I'm really excited about is that since this work, like in this year, these 4 centers are now enrolling patients for an active surveillance BCC study prospectively, and we're collecting the same measures and the same outcomes from these patients. And our hope is to be able to combine our data and have a US-based prospective study of active surveillance, because some of the criticisms we receive are like, well, this isn't in the US. So now we're doing in the US, and the exciting part is that we have partners. It's not just us here who think this is a good idea. So going back to, this initial area I mentioned of my research, which is this intersection of dermatology, technology, and public health. I'll mention briefly some data about our current work on longitudinal monitoring of skin disease. And as you all know, COVID really accelerated the use of telemedicine. And this is some data from Stanford on the use of telemedicine appointments across all specialties in those early phases of the pandemic, and divided by age. And as you see, this use of telemedicine increased for everyone, but was lower for patients over 65. But I believe that at this point, really, thinking about digital access for older adults has become much more commonplace of a conversation and much more acceptable, not just among our patients, but also among the tech industry. And so one of the problems we're trying to address with our current study is this issue of skin disease severity varying over time. So now I'm shifting away from talking about skin cancer to talk about inflammatory skin diseases or ulcers, conditions that often affect older adults as well. And what happens is if you think about skin severity on this axis, kind of from better or worse, it varies over time, but the dermatology visits are at arbitrary time points and often do not match the course of the disease, are just based on when the scheduler had an appointment or when you had availability. And so what we're trying to do here is address this loss of data, the granular data in between, by collecting images remotely from patients from home. We also performed these qualitative interviews with 23 dermatologists to explore their experiences for using telehealth in older adults, and really summarize their recommendation, which is there's tremendous need for this in dermatology for older adults because it's so difficult to get into appointments, and often because issues relating to dermatology, as you probably know with your clinical practice, you need a dermatologist quickly, not in 6 months when the next appointment is available. With feedback from patients, physicians, and with the design firm IDEO, we designed DORA. DORA is an acronym for dermatology and older adults, but everyone told me they don't like to be called older adults, so we just call it DORA. But just so you know, that's where it came from. The word older adults is in there. And really, the idea is to make a very user-friendly tool that can collect symptoms and is easy to use, can be used from home, and can monitor lesion change over time. My hope was to use this for BCC. So my initial hope was, okay, can we create an active surveillance for BCC home-based intervention, so people do not need to come in and automatically get biopsied. And at the same time, we can safely monitor them from home to address that challenge that I said of neglect. So often the surgeons will say, well, are you neglecting them? But if we had some way to say, no, we're watching them, but we're watching them at home. And that still is my hope. However, this current study excludes skin cancer for practical reasons, specifically that it's funded by NIAMS, which is the Skin Institute, that if you ask for funding for cancer, they divert you to NCI, and then NCI says, we don't care about basal cell because it's not a real cancer. So right now we're developing this tool for chronic inflammatory skin disease, but the idea is it could be used for any condition. And I'll just show you some photos of, that we get from patients. And this is a lesion that, in theory, when you see it, you could be suspicious. It's a black lesion on acral skin. But with a series of photos, you see it resolves. It's just blood, it's just trauma. And if you look at a series of photos, really that can really alleviate a concern. This isn't a basal cell, but this is a patient who, in theory, could have been biopsied based on the first photo. But of course, with a longitudinal series of images, does not need to. We have lots of examples of these photos of longitudinal images collected from home, and the photos aren't perfect, and some of the difficulties here are optimizing image quality and assessing really how usable these images are, both for clinical diagnosis and eventually for computer vision and AI analysis. We've also started using it in babies and for infantile hemangiomas, and the reason for this is when we presented some of this work in dermatology, a lot of colleagues came up and they were like, wait, I have another use case, patients who are discharged from the ED, but I worry about them because, I've sent them home and I think their drug rash is going away, but I don't know. And can I use it to monitor them? Or in this case, our pediatric dermatologists who are like, parents are never believe me when I say this has shrunk. So can we have something where they can see that the hemangioma is actually slowly decreasing? We're using it for hidradenitis suppurativa, which is another, very painful chronic disease where, again, the flares of this disease happen at always the wrong time and when you're not with a dermatologist. So trying to collect data, not just from easy to photograph areas like the face or the arm, but also folds that are harder to image. And then, we're giving feedback if a lesion, for example, is out of focus to try and improve the quality of photos. And, so far we have recruited, let me see, I'm cognizant of time because I want to tell you about our center. So maybe I'll briefly take us here. So we've recruited 100 patients over 65. The R1 that I mentioned is to create a longitudinal image library of skin disease in older adults. So we're trying to recruit patients over 65 and particularly trying to recruit patients with diverse skin from diverse backgrounds and skin colors. We have over 1,200 patient-submitted images collected. Our average follow-up time is 7 months. And about 65% are in this young, old, 65 to 74, about 53% female. And 60% of this cohort, which is all over 65, upload images within 24 hours, which to me is always remarkable. I have my fellows screen all the images to make sure they're of good quality and also send any concerning lesions for review. And we get this update every week. And I still, even though we're a year into this, I'm like, they're still sending us photos. It's amazing. But because we've made it so easy, it's a text message with a link. So no password, no app, no need to, download any special software. And so it's very user friendly. And, here are some example images. This is one of my favorites. This person always photographs their leg on the toilet. So it's like consistent without fail because we want consistent backgrounds. And then, yeah, so just some preliminary insights. 60% of images are uploaded within 24 hours. 85% of all our images are scored high on a scale of how useful it is clinically and the quality, the focus of the image. And our preliminary analyses show that image quality does not significantly vary by age, gender, race, employment, or income, but it does by marriage. So unmarried individuals, basically submit lower quality images, and maybe that is something to think about for support. Now, this is interesting to me. I don't know the data in geriatrics, but in melanoma, there is data that unmarried individuals present with melanoma at a later stage because their partners tend to catch things earlier. That's the theory. So that's interesting. And then interestingly, the highest consistent image quality is photos of nails. And I don't know if that's just because it's just easier to focus. So that's one thing we've learned. The other thing we've learned is that the response rate, and we've iterated on this, varies a lot by skin disease and affected area. For example, when we were recruiting early on, I had two fellows, one focused on rosacea. This is before our older adult study, and one focused on hidradenitis. And consistently, when they would present to me, the rosacea signed fellow was like 95%. Everything's complete. And the HS, the fellow working on HS had rates of 30 or 35% participation. And of course, it had nothing to do with how good they were, even though one person was very proud, but we found it's very easy for patients to photograph their face because you can do it any time of day, anytime you get the text message, you can, but if you have to undress, find a private room, get good lighting to photograph your armpit or your groin, obviously that is harder. Our fellows who also didn't have kids realized the best time to text parents with babies and came to me and they were like, you can't, if they won't reply, if it's between 1 and 3, because babies nap. But if you do it at bath time, that's when the baby's naked and you can photograph it. So we're able to titrate and change small things like what time the text message delivers, what day of the week, as well as the phrasing, obviously. Just a lot of thank yous for our team. And then maybe I'll spend 5 minutes telling you about the Center for Digital Health. And there is a geriatrics tie at the end, but essentially about a year ago, I took on this very exciting for me role leading the Stanford Center for Digital Health, which brought me to the Department of Medicine. So now about half my time is in the Department of Medicine. The center was small, but I was really excited to build and grow it. It's a research center, which is always fun, but our mission is to bring together the best and the brightest minds of Stanford, Silicon Valley, and the world to answer pressing research questions in a way that is both scientifically rigorous, but also ethically sound. And, we have these 3 roles: a convener, doing events, bringing together other digital AI, bioinformatics researcher, catalyzer. We offer seed grants. And also, we want to be a thought leader in digital health. And so far, we've awarded 250,000 in pilot grants. We support digital health scholars that are at that fellow, instructor, junior faculty stage. We have 42 faculty affiliates, and in partnership with the Times Higher Education, we co-hosted one large digital health summit. We're planning another one in October. And we just announced our next pilot award grants. And unfortunately, it's for Stanford faculty, although maybe I should rethink that. But I did want to say, this is our advisory board and our team, but I did want to say our second priority area is digital solutions for healthy aging, cognition, and longevity. And so everyone's like, aging? Why is aging in this? Because last year and I was like, I had to wait a year. But it's really exciting because last year we got 81 proposals. We were able to fund 5, but a lot of people came up to me and said, like, even though you didn't fund us, the fact that I had to write this grant means I'm doing it anyway. And so I'm really excited to get people thinking about digital health and aging. And then maybe I'll go a little bit backwards. And this is our wonderful team that's growing, and our advisory board, which is just incredible and has been so helpful at guiding how we essentially build a center in an academic institution, but with with ties to the tech world as well. So this is a combination of academics, philanthropists, and technology leaders. But their common feature that I'm so, proud of is that everyone here is brilliant and also very humble. And so it's been really a joy to build this center with this team. Maybe I'll stop there so that we can have time for questions. So thank you for having me. Yeah.
While people are thinking about questions, I just want to read a little plaque for you.
Ooh,
Thank you for being one of our visiting professors.
thank you.
And let's see if I can open it correctly. Yeah. And,
Oh, wow, it's beautiful.
and it says about a teacher affecting eternity. So thank you for all that you taught us today.
Oh, nice. Thank you so much.
Thank you for being with us. And maybe I'll lead off with a question. Question of sort of a little bit about your experience in changing a paradigm, because did you get sort of, universal great idea? Or tell, I don't know if you want to tell a little bit about your experience.
Yeah.
And now and I also had a question, has it now kind of seeped in, and do you still get that kind of pushback? Or how have things changed?
Yeah, no, I got a ton of pushback early on. As you probably know, the dermatologists were not happy. In fact, I still remember being in one derm meeting where the surgeons asked me to present in the derm surgery meeting, and someone stood up and said, "You're a traitor." And I was like, oh my gosh, that word. And but then what happened was the geriatricians were like my people, and I had Meg Kren and Ken and you and all these people, and my K was funded by NIA, by the aging community. And so, but then what happened was, obviously that wasn't all dermatologists, because I would also get these messages, like people wouldn't say it out loud, but they would come and say, I totally don't treat BCCs, like, especially if it's a 90-year-old I like, I don't, I just don't, so people were already doing active surveillance. They were already doing watchful waiting, but they didn't have a way to articulate it. They didn't have a way to document the conversation, but they were doing what was right. And so there was a lot of pushback initially. I think for the fellows, one thing that was helpful, I remember when I was thinking, if you're trying to shift a paradigm on one area, do you take the risk and make that your only career? And what I did was I also worked on indoor tanning in parallel, and tanning beds and indoor tanning was something all dermatologists agreed was bad. Like everyone, it was so not controversial. We all thought they were bad. They cause cancer, they cause melanoma. We all hate them. And so by continuing research on tanning beds are bad, I was able to, that was kind of my backup plan, is like, I'm still on your side. I'm still, doing research that you think is valuable. And the other thing I did carefully was made sure my trainees, when they were applying for residency, I would very carefully say, like, you work on the tanning bed one, don't, because when you go interview, if you have to defend this, you're going to get grilled. So my trainees, I made sure were, except the ones not going into derm at that stage. But then eventually what's amazing is now the main derm textbook has a section on optimal treatment in older adults that mentions watchful waiting. Even the guidelines, the NCCN guidelines, have a section on watchful waiting and life expectancy, and they highlight that. And recently I even I went on to ChatGPT. Admittedly, that is probably citing my own papers, but if you ask ChatGPT how to, approach an older person with basal cell, it will talk about values. It quotes your papers, probably, Louise, and patient preferences and patient values. And so I think things have really, really shifted, and now it's completely normal, thanks to all the work that you've done here, to talk about these things. But it was definitely hard and scary at the beginning, but having my geriatrician research friends was, kept me going. And then having another area that is not controversial, just in case you need to pivot. But yeah. And yeah. Oh,
So Dr. Linos, you, so when we advise like our early career faculty and trainees, we really emphasize the importance of focus.
Oh.
And having this niche that you can follow for your career. And it seems that you have been interested in a lot of stuff and have been wildly successful like having broad interests and we like, oh, how do we reconcile?
How do you reconcile that? Sorry, I'm not a good,
Do you really focus or like
Well-
what do you advise sort of
yeah.
the young scholar, teacher who's interested in everything?
Yeah.
Doesn't want to be like doesn't want to narrow themselves.
Yeah, no, I still think focus is important, even though I struggle with that. But for me, the thing that was helpful was just knowing my exact metrics, like what were the tick boxes I needed on the focus. Like I needed a K, I needed after a K, I needed an R type grant. But then once you tick those boxes, then you can do other things as well. So I was very interested in gender equity and in academic medicine, and that was something that I'm genuinely very curious about, wanted to work on. I've never had a grant on that, but because I've ticked okay, I have a K, so my chair is happy for my promotion metrics, or I was lucky enough to get a DP2 while I was here, which is a New Innovator Award, if anyone's interested in those. Which gave me, again, like some checkbox credibility. But then I could go, the DP2 is a wonderful grant because you don't have to submit research aims. They essentially fund the investigator to do work in an area, but you don't have to submit progress reports in the same way that you do with an R01. So I think having focus and knowing what your milestones are for success is important. But once you do that, then it's almost like, eat your vegetables and then you can have dessert, maybe. I don't know.
Great.
Yeah.
We actually have a couple questions on the chat I can read. It says, do you have partners from other countries to build your image databases, especially for covering lesions less common in the US, such as tropical diseases? If not, do you have any plans to establish?
Yeah, thank you for that question. I would love to do this, and we're currently working with the IRB to get IRB approval to recruit in other countries. And we would love, I don't know which country.
Brazil.
Thiago. Oh, okay. Hi, Thiago. Yes, would love to work with Brazil. So the IRB has told me so far is we have to get one-on-one partnerships, the IRB approval in that country, at Stanford. But yeah, it's so important, not just for the topic you say, like tropical diseases, but also to get different skin tones and skin colors, because that in dermatology, that is the biggest issue with image libraries, is that they're all the AI data sets are trained on white skin. And so for both those reasons, that's really important. So yeah, if you know anyone that wants to work on this, it's a lot of IRB work to get it set up, but it would be great. Yeah.
Well, that actually goes right into the second question, which is around the resource images for ethnic skin and how to develop guides, and PCPs could have that as a resource.
Yeah. That's a really good question. I don't know about resources for PCPs specifically, but that's a great idea and something we should develop. And Jenna Lester, who's here at UCSF, and Leandra Barnes at Stanford, who's leading our Skin of Color clinic there. They're both friends and colleagues and former mentees who I can talk to about maybe, we've been thinking about image resources. It's just fresh on my mind for oncologists to look at how chemotherapy patients lose their hair and how it grows back, because we realize that, patients don't have easy access to this longitudinal, like this is how your hair will look for a while and this is how it'll come back. And so we're building that right now for cancer patients, but we should do a similar resource for PCPs. It's Mike Steinman, a terrific talk. Hi, Mike. Sorry, I'm reading. What suggestions do you have for inspiring the creativity to think outside the box? So you need these mentors, yourself included, Mike. So by no means do I claim that any of this was my idea. Obviously, I'm following in the footsteps of all the work you did for, mammography screening, for colon cancer screening, Alex and Say's work on, life expectancy. So having good mentors, I think is key. Occasionally, I will have a good idea, and it's always at a really, really random point in time. And so just giving yourself time, I guess, to be bored and to be in nature and have downtime, I think is important for all of us. Because those ideas never really come when you're at work, I think. But I think also ideas come out of collaboration and not by yourself. So being in an environment that has amazing mentorship, like all of you guys role model here, is key.
Probably
Yeah.
bringing together different areas, right? Dermatology and geriatrics. Like I actually think bringing
Yeah.
together kind of, you know, disparate areas,
Yeah.
and being able to be a bridge like you are to get those two groups
Yeah.
together. Right.
Yeah.
So.
I'm really excited about one good idea came on the plane, Mike. I'll tell you, this was a few years ago when I was sitting next to this blind man who was so he was completely blind, but was so good at moving around the plane. And, you know, I kept watching him. I wanted to help him, but he needed no help because I kept watching how he would pour his drink in the ice. And I was like, is it going to spill? Is it, you know, and he was just perfect and could go to the bathroom and knew exactly where his seat is. He wasn't asking, he would just go right. And I was like, how is this possible? So it turns out this amazing man was born blind and did a PhD in organic chemistry by printing out the molecules and feeling them instead of visualizing them. And, you know, and talks about accessibility and, you know, has a TED talk on, you know, the benefits of being blind on other senses. So we got chatting, and at that moment, we were like, well, there can never be a blind dermatologist. This was 5 years ago. We're like, yeah, some fields, like probably not. And then, you know, a few months ago, I was sitting there and I was like, wait, I was on the plane again. And I was like, now with AI and computer vision being so good, I think there can, you know, we're getting to the point where there probably can be a blind dermatologist. So anyway, I was very proud of having that aha moment on a plane, like, so I might write that up at some point, but yeah.
Are you
Yeah.
still writing any viewpoints?
Well, this is one. I might make this into a viewpoint about AI helping accessibility. So we'll see if, yeah, with physicians. I don't know.
We are at our time, so.
Okay, thank you so much for having me. Thanks, Lee.